for the first time today. يعني. Next speaker, our colleague, Dr. Mohamed Saied, exploring genicular artery embolization as a novel technique for knee osteoarthritis. Dr. Mohamed.
Dear Professor, dear colleague, thank you. I will talk about a new promising technique regarding genicular artery embolization in the management of knee pain secondary to osteoarthritis. Knee osteoarthritis is a major cause of morbidity and disability with a reported prevalence of 25 to 30% of the population. Chronic knee pain secondary to osteoarthritis requires diverse lines of medical approach with subsequent decrease in the overall quality of life. We have a lot of causes for knee osteoarthritis. We are classified to non-modifiable primary cause, the aging and gender female on the top of the list, some of genetic and racial factor. And we have modifiable secondary causes of knee osteoarthritis. We have articular trauma, multiple prolonged standing and repetitive knee bending in some occupation, malpositions of limb in cases of genovarus and genovalgus, and some cases of scoliosis with abnormal weight and height distribution. And one of the most common causes nowadays is obesity. We traditionally use always is gold, based on that knee osteoarthritis is a matter of degenerative disease related to wear and tear mechanism only. But now we have a new theory. We have a new theory based on different autopsies. It has been recently discovered that there is associated chronic inflammatory reaction induced by different types of cytokines and inflammatory catabolic mediators through abnormal new vascularization called angiogenesis. And this is our idea. It's our idea in genicular artery embolization is this abnormal angiogenesis. The pathophysiology of knee osteoarthritis, we all know that articular cartilage is composed of primarily of type 2 collagen and proteoglycan, chondrocytes and water. Healthy articular cartilage constantly maintain an equilibrium between each of composition, that is the articular degradation and the articular matched by resynthesis. In the process of knee osteoarthritis, any injurious factor triggers the degradative cascade, disrupting this equilibrium, resulting in overall loss of the collagen and proteoglycan, chemotacting a lot and more of catabolic mediators and so on. So we are in a vicious circle, need to be broken. So our target in genicular artery embolization is to break this cycle, occluding these abnormal vessels and preventing the transport of these catabolic and inflammatory mediators. Let's start to know the vascular classic anatomy of the knee joint. The knee joint, one of the most common highly vascular joints in our body, taking supply from branches of the distal femoral artery branch from here, with the main supply of the medial compartment of the knee joint via the descending genicular artery with the characteristic inverted Y bifurcation shape. And some from the popliteal artery. On the medial aspect, we have the superior medial genicular artery and inferior medial genicular artery supplying the medial aspect of the knee compartment. On the lateral aspect, we have the superior lateral and inferior lateral. And some cases, we have the anterior tibial artery supplying anterior tibial recurrent branch. We stressed on the descending genicular artery. We have a lot of cases with this accused genicular artery with the musculoarticular branch supplying most of our cases with knee osteoarthritis. The radiological finding for knee osteoarthritis, the characteristic finding depends unfortunately on the plain radiography. We have some points to characterize knee osteoarthritis as osteophytic lipping, joint space narrowing, tibial spiking, and multiple subchondral sclerosis. We have the most common scoring system called Kellegren and Lawrence scoring system. This system is characterized by Grades from 1 to 4. 1 is the most easiest and simple form. The just doubtful joint space narrowing until to grade 4 with marked joint space narrowing and marked subchondral sclerosis and some sort of knee deformity. Traditionally, the management of osteoarthritis designed for no pain, alleviating this knee pain. So non-surgical management approach for the most of the patient is firstly patient education, lifestyle modification, and weight reduction. And some medications like oral non-steroidal and some sort of systemic non-steroidal. And nowadays, intra-articular injections like hyaluronic acids and chondroitin sulfate and steroids. The most common adverse effect of these medications, GIT ulceration, bleeding tendency, and renal impairment in case of non-steroidal drugs, and common adverse effect now of the intra-articular injection like infection, skin discoloration, site of the injection, pain and swelling, what's called cortisone flare-up. So after all, here the interventional radiology can offer a novel minimally invasive treatment for knee pain secondary to osteoarthritis. This is genicular artery embolization based on the idea of abnormal angiogenesis. So our indications for the patients above 40 years complaining of mild to moderate new osteoarthritis as determined by Kellegerin scoring system, grades from 1 to 3. Why not grade 4? Because grade 4, he lost his articular cartilage. He has no any favorable beneficial effects from genicular artery embolization. At least this pain refractory to conservative medical therapies for at least 6 months. Contraindication for our intervention, severe knee osteoarthritis, as I mentioned before, Kellegerin grade higher than 3, and current local infection or malignancy, and prior intra-articular injection for at least 6 months. And the most common facing factors in our generation is a body weight greater than 150 kilogram. Pre-procedure measures, patients were evaluated before procedure by full history taking with emphasis on the specific site of knee tenderness. The specific site of knee tenderness will be the indirect factors that lead us to the accused vessels. As we mentioned, we have a medial aspect and lateral aspect. According to the site of the tenderness, we can expect the abnormal vessel. So we do VAS score for the pain severity for all the patient, and the functional scoring system applied for the knee osteoarthritis that's called WOMAC scoring. WOMAC scoring system is different from VAS score. That WOMAC score is functional scoring. Baseline plain X-ray was obtained and evaluated using the scoring system, and we requested the baseline MRI. Why MRI in our cases? Because we need to categorize our patient to pure osteoarthritic patient or comorbid patients, because the beneficial outcome will be favorable in case of pure osteoarthritic patient. And we asked for laboratory testing, coagulation profile, and serum creatinine level. Our technique via right femoral puncture approach. We have 2 approaches in our cases: antegrade approach to the site of the affection or contralateral approach, according to the performance preference. As we mentioned before, we have the superficial femoral artery here with the descending genicular arteries characteristic inverted Y bifurcation, and the medial aspect we have superior medial and inferior medial, and on the lateral aspect we have superior lateral, inferior lateral, and the anterior tibia recurrent. So we do digital subtraction and geography after access to the superficial femoral artery, followed by selective catheterization of each vessel using 2.7 or 2.4 prograde microcatheter or any microcatheter. Embolization was performed using microspheres particle 150 to 3 micron, mixed with water-soluble iodinated contrast with ratio 1:1. As you see here, this is the digital subtraction and geography for the distal superficial femoral artery and the popliteal artery, as we mentioned. Our aim to reach to this characteristic inflammatory plush. Our patient here was complaining of right side or medial aspect knee osteoarthritis. After cannulating the superficial femoral artery and descending genicular artery, we noticed that he have the characteristic inflammatory brush that is seen obstructed or occluded by the particles. And so on here, the descending genicular artery supplying the medial compartment with bone sclerosis, bone denudation, and ulcers. Some illustrative cases. We have a 49-year-old female patient presented by left knee pain of 9 months duration, more on the medial aspect with BMI about 3-4, Kellgren-Lawrence scale about 3. She is surgical-free, trauma history negative. This is a digital subtraction angiography for the superficial femoral and popliteal, as we mentioned. And this is a characteristic inflammatory brush of the inflammatory mediators and catabolism. So, after occlusion, we have absence of the inflammatory brush. The case 2, 51-year-old female patient presented by a left knee pain of 2-year duration, more on the lateral aspect, BMI 36, Kellgren-Lawrence scale about 3. We noticed most of our patients come to our clinic with Kellgren-Lawrence scale grade 3 because grade 1, grade 2 always take a conservative medication, either systemic or local, topical medication like non-steroidal anti-inflammatory, because in a baseline VAS score was 8 and the baseline WOMAC score with 83. Look for the intra-articular inflammatory plush related to the accused vessel. After embolization, no inflammatory plush and VAS score improved, became 3. Some complication like immediate complication, puncture site hematoma or contrast allergic reaction. The most common or most adverse effect seen in genicular artery embolization is the distal non-target embolization if the operator injecting very rapid, like cutaneous branches causing transient cutaneous ischemia, or to vasa nervosa causing plantar paresthesia. Both of these complications are self-limiting, resolved without any intervention for 4 weeks. Follow-up using VAS score and WOMAC score, as we mentioned. The rehabilitation is a cornerstone here. After restoring the highest possible range of motion and mobility, full muscular control, because adequate rehabilitation is an important requirement for successful GEE. Our conclusion here, genicular artery embolization hold promise an effective minimally invasive procedure for the treatment of knee pain secondary to osteoarthritis, especially in isolated pure osteoarthritis. Patients could be introduced as a safe technique with no serious complications. This is our experience in our unit with Dr. Mohamed Saied, and thank you.
Thank you, Mohamed.